This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard, a cardiology specialist of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
This is MyHeart.net, and today we're going to talk about familial hypercholesterolemia, or FH, and it's particularly going to be interesting for the younger patient population. With us today, we have Dr. Pradeep Natarajan, who's Director of the Preventive Cardiology at the Mass General Hospital. He also has an endowed chair, the Fireman Endowed Chair in the Vascular Medicine at the Mass General. He's also Associate Professor of Medicine at Harvard Medical School. So Pradeep, thank you very much for taking the time and being here for us.
Yeah, my pleasure. Honored to be with you and looking forward to discussing.
Thank you so much. You know, Pradeep, it seems like when we're young, we're invincible. I mean, and particularly if we talk about cardiovascular disease, that's mostly for people that are just kind of the older patient population. Despite that, and all the advance that we've had in preventive medicine, we're seeing just an increased incidence of myocardial infarction in the young. Particularly in the last 20 years, we've seen a double actually of premature myocardial infarction. And I think these studies have shown a link between familial hypercholesterolemia, or FH, and this increasing problem of heart attack in the young. And I should know a thing or two about that because I'm French Canadian. I come from Quebec, and we have a lot of FH, or familial hypercholesterolemia and premature coronary disease. So tell us a little bit, what is FH and what does it mean for the patient?
Yeah, so FH, or familial hypercholesterolemia, is a condition that the scientific and clinical community have known about for better part of the 20th century, obviously going into the 21st century. It's a condition that is characterized by severely elevated blood cholesterol, primarily LDL cholesterol, that's the bad cholesterol. And the important clinical consequence is premature heart disease, namely premature myocardial infarction or heart attack. Now, the molecular hallmark is typically a mutation that occurs in the LDL receptor. The LDL receptor sits on the surface of liver cells, is involved in clearing the LDL particles. And so if the receptor is not working, LDL particles stay in circulation. And also the liver thinks that there isn't much cholesterol or much LDL because the receptor is not working. And so the liver starts going on overdrive and starts producing more cholesterol. So you get in this vicious cycle of very high cholesterol. And as I said, the major consequence is cardiovascular disease, but for many and, really all patients, we can often find this by measuring blood lipids. And a major reason why current guidelines recommend screening for lipids for people starting in their 20s is really to identify familial hypercholesterolemia.
So as a clinician, I know we tend to underdiagnose because I think we don't know enough about it and we miss it. What is the best way to make a diagnosis of familial hypercholesterolemia and whether we're dealing with one gene or two alleles, that are missing? I guess for us, the adult, we're going to see mostly heterozygous familial hypercholesterolemia, won't we?
Yeah, Alan, recognition is the major issue. When we think about cholesterol and heart disease, as you said earlier on in this recording, that those things happen often later in life, even if they're happening prematurely. People are not thinking about that in their 20s. They're not usually thinking about their heart health. But the science has become increasingly clear that what you do early in life and what your risk factors are early in life matter a lot. And so, people feel alive and well and invincible, including into their 20s and even up until middle age because they've been feeling fine. But plaque buildup starts early, risk accumulates, and making these interventions earlier in life is key. And where there is the clearest opportunity is in the context of FH, because we have decades of research, almost a century of research that has strongly linked circulating cholesterol with cardiovascular disease. And the longer it's elevated, the more it magnifies your future risk for heart disease. And so earlier identification and earlier intervention is critical. And that really just starts with lipids. So the underdiagnosis is often people are just not getting their lipids checked. They're just waiting much longer. And that could be for a wide variety of reasons why that might happen. And then if it happens to be checked and if it's abnormal or very high, because people are feeling fine, either they're not as inclined to take a medicine. A preventive medicine is often a lifelong medicine. And so reconciling those can be really challenging, even though the science is clear. Now, for diagnosis, there's some controversies in diagnosis, meaning individuals with FH will have very high cholesterol, but lots of people with very high cholesterol, that's an LDL cholesterol greater than 190, that's traditionally thought of as severe hypercholesterolemia. Turns out actually most of those individuals don't have FH mutations. They likely have other genetic contributors that are, less well defined. We've been working on characterizing what those features are, but it's probably a mix of genetics and lifestyle for a bulk of individuals. A fraction of that related to familial hypercholesterolemia. So everybody who has severely elevated cholesterol, we should work on lowering their cholesterol. That could be by means of medicines as well as lifestyle modification. Now, individuals who have FH, there is further risk beyond that measured LDL cholesterol, likely because they have been living with very high cholesterol for a long period of time, where the environment and the lifestyle factors, may not be explaining that distribution difference as much. And so recognizing that it's FH, we should be, even more strong about introducing these interventions, particularly with meds, because lifestyle is often insufficient, but does complement the strategies. And we do recommend being more aggressive in those patients. So ensuring that we get fasting lipids is critical. And for individuals that we suspect FH, current consensus panels do suggest performing genetic testing to see if we should be particularly aggressive in those patients.
Well, let's talk about treatment a little bit. When I was growing up, I had a great friend of mine that he had FH and he was taking this cholestyramine. A very smart guy. He ended up going into actuary school. But I know the treatment has evolved a lot in the last 50 years, and nobody gives cholestyramine anymore. We have so many good treatments. Tell us about what's available now.
Yeah, first line is statins now. It's been that, since the 1980s, 1990s, now obviously in widespread clinical practice. Lots of comfort with that medicine, including with long-term follow-up. And this is really important for especially younger patients who may be placed on this medicine or we're recommending, who are concerned about what the long-term implications are, because these are often lifelong preventive medicines, or cholesterol lowering will be lifelong. And we have lots of great long-term data in statins, and they're all very safe medicines. The main thing that people read about are muscle complaints. It turns out that is a little tricky to analyze, because as people get older, more of them get placed on statins, and muscle complaints are pretty common when you're older, so there is an overlap. Actually, if you look at blinded randomized controlled trial, when people don't know if they're on a statin or a placebo, the rates are almost identical between the two. But there is a subgroup of individuals where it's reasonably reliable. They've actually done some pretty nifty trials on statins now for those patients, where they blindly take blindly as in just randomly go back between a statin and placebo. Actually, most of those individuals don't have a clear correlation of their symptoms between statin and placebo, suggesting it's probably an even smaller subgroup where it's bona fide. So anyway, very safe medicine, excellent long-term side effect profile. And now there have been other medicines. There's a medicine called ezetimibe, goes by the trade name Zetia, but has been generic for a long time. It's a non-statin medicine. So statins inhibit this enzyme called HMG-CoA reductase. That is the enzyme that's on overdrive, overproducing cholesterol in the liver. So it works very well in FH patients. Ezetimibe inhibits NPC1L1. That's an intestinal transporter of cholesterol. Cholestyramine, as you mentioned, is not frequently used. It is used. It can also inhibit dietary absorption of cholesterol. It's largely binding up the cholesterol in the gut. That does lead to a lot of GI intolerances. So it is generally not a first or second line medicine, but it can be used potentially. However, there are now many, many more medicines that one would not have to use. That class of medicine is very uncommonly used. Another class of medicine that has been available now for almost 10 years, about 8 years now, is a class of medicine called PCSK9 monoclonal antibodies, or PCSK9 inhibitors. PCSK9 is involved in the regulation of the LDL receptor. And if you inhibit it, it leads to more LDL receptors, better clearance of LDL cholesterol. And those are very effective at lowering LDL. They are injectable medicines that you take about every 2 weeks, and you inject yourself under the skin. It's almost, and these are pre-filled syringes, so pretty well tolerated. Excellent at lowering cholesterol if needed on top of those additional medicines. There's yet another approved medicine called bempedoic acid, or Nexletol. It inhibits an enzyme called ACLY, which is also involved in the cholesterol synthesis pathway. And it's a pill, and that also lowers cholesterol, pretty similar to ezetimibe. And lastly, there is another mechanism for inhibiting PCSK9. It's a PCSK9 siRNA that is administered about every 6 months, and it gives much more durable lowering for PCSK9. Relatively new, but now available. Also another medicine in the armament. And so now with all of these different options, we can typically find the right set of medicines for the right patient to ultimately get their cholesterol at goal.
I know there's still a lot of studies going with the small molecule, inclisiran for patients with familial hypercholesterolemia. There are some novel targets that pharmaceuticals are developing, particularly this. I didn't know much about the angiopoietin 3 protein. Can you talk to us a little bit about that?
Yeah, ANGPTL3 is another molecule that's involved in the regulation of ApoB containing lipoproteins. ApoB is the key protein that is a hallmark of all atherogenic lipoproteins. ANGPTL3 is kind of involved in the regulation of both triglyceride-rich lipoproteins, LDLs, and to some degree HDL, just given those relationships. And it's been observed that individuals who are naturally deficient in ANGPTL3, largely because of mutations, they have lower LDL, lower triglycerides, and also lower HDL. And the data seems to suggest that they may also have a lower risk for heart disease, which would make sense if they have, at minimum, lower cholesterol. There have been medicines that are ongoing in development to inhibit ANGPTL3, one that is available in clinical practice. That medicine is called evinacumab, and it's an infusion that you get. It's only FDA approved right now for homozygous FH, so very rare, and is very good at lowering LDL cholesterol. That being said, there are other companies that have been developing medicines to inhibit ANGPTL3. It's attractive because it's a different target, and it may be particularly attractive in FH patients because, as I said, PCSK9 is involved in the regulation of LDL receptor, and if you inhibit it, you get more LDL receptors. Now, if your LDL receptors are dysfunctional, that may not be the best strategy for FH patients. Turns out, particularly in heterozygous FH, that means half of the LDL receptors would be dysfunctional. So inhibiting PCSK9 still actually works pretty well. However, in homozygous FH, particularly those who have true null mutations in LDL receptor, having more LDL receptor doesn't really help. And so inhibiting a different target like ANGPTL3 will work pretty well. So anyway, companies are also investigating whether there is a role outside of just homozygous FH, which is the only one where it's currently available today.
Very interesting. If we look into the future, and as you mentioned, some people are born with a certain genetic variants and the loss of function, for example, of PCSK9 or angiopoietin. Would it be possible that one day you come for a once in a lifetime infusion and just kind of correct a misspelling in your gene and do a little gene editing and actually correct what's wrong and maybe prevent heart disease and have a lifelong, kind of a low level and low exposure to LDL and decrease the problem with heart disease?
Yeah, so now is, over the last decade, 2 decades, we've had lots of advances in understanding what the consequences are of naturally occurring genetic variation. And now in this last decade and onward, there has been a lot of excitement in genomic-based technologies to potentially rectify some of those risks, whether individuals have risk alleles or not. Now, this is largely in the form of gene editing. And gene editing kind of comes in 2 flavors, whether it's in the germline or it's in the somatic tissues. In the germline, meaning gene edits that would get passed on, would be permanent in the individual and then get passed on. That is less commonly done today, and that may take a while, if ever we get to that point. So most of the drug development has been somatic gene editing. So edits that would be permanent and fixed in that individual, yet not passed down from generation to generation. And that comes in 2 flavors, whether that's happening in the body or if the gene editing is happening outside of the body. There are pretty mature drug development programs for hemoglobinopathies for gene editing to at least address some of the targets that are important in regulating hemoglobin. Those are done outside of the body, and then bone marrow is transplanted back in. It's for a newer technology, there's some advantages because the gene editing machinery never enters the body, but some disadvantages because at least for those, one would have to undergo a bone marrow transplant. Now, what is being investigated for cardiovascular diseases, including for these cholesterol targets, is in vivo somatic gene editing. And drug delivery to the liver is already pretty mature. And so now it's delivery of machinery of gene editing to the liver. And one can introduce mutation that occurs in any of these genes to lead to lower gene expression. And it doesn't need to occur all throughout the body. Most of these genes that are involved in lipids are liver expressed genes. And for some of these drug targets, the data suggests that could be safe because there are individuals who live without any PCSK9 in their body because they have loss of function mutations and no PCSK9 expressed in any tissue, and they all live to adulthood and they have lower risk for heart disease. That's a major reason why it's a attractive drug target. And so for that reason, also attractive from a gene editing perspective. Same for ANGPTL3. So colleagues are working on this, and it's fairly early in non-human primates. It looks pretty promising as far as its efficacy in lowering cholesterol, and it's exciting because for people like many individuals, especially when they're younger and at risk, including for FH, people don't want to take medicines, and this may be a way to not take medicines where you have one cure for the most important risk factor for that person, which may be severe hypercholesterolemia, and then they live the rest of their lives. Now, you also brought up the possibility of now for the specific defect, changing that defect. That is yet another flavor, because what I was saying before, this gene editing is basically a new way to drug a drug target. Now, less so in the cholesterol space and FH space, but some, has been described for hypertrophic cardiomyopathy and really applied in like mouse models, showing examples of if there is a mutation and then changing that mutation. And you would have to do that very early in life, like in development, really to show a benefit. So lots of inherent risks. There has been demonstration of feasibility. And, maybe at some point we will get there, maybe in our lifetimes. I don't know. Lots of ethical considerations, lots of safety considerations. So it certainly is an exciting time. And really, cholesterol, FH have been on the forefront of this.
Yeah. Fantastic. I mean, I think the future is bright for these patients. It's improved so much, in the last several years. So I want to thank you very much, Pradeep Natarajan, who's Director of Preventive Cardiology at Mass General at Harvard. Thank you for what you're doing. World expert on the FH.
My pleasure. Thanks for the invitation. Really a pleasure. Take care.
Thank you, Pradeep. Appreciate it. Have a great weekend.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.